Uh, can you see my screen? Like, am I sharing already or not? Oh, okay. Okay. So let me share. Okay. Okay. Cool. So you guys can now see. So let me take my time with the treatment now. Just go over it from the beginning because I think it's very important. And I want you to look at it in this way. So steroids for anybody who comes in that you suspect of having genital arteritis, right? You don't need to wait to confirm. You don't need to wait to confirm your diagnosis. Just start the steroids straight away. You start very high doses of you start very high doses of steroids, as I said, 1 milligram per kg, so like 60 milligram, and then you can send a person for a temporal artery biopsy to confirm the diagnosis, right? And as I said, always be careful in somebody who is coming with you started GCA, even the person steroids, and the person says after a week that my headache is still not gone. You really need to evaluate your diagnosis because it has very excellent response to steroids. And then, sorry, you can see improvement in your inflammatory markers with steroids. You give high dose pulsed steroids when they are when there's GCA with visual symptoms, right? So this oral 60 milligram is for anybody, let's say somebody has come in 80-year-old, headache, scalp tenderness, some fevers, and then let's say some jaw claudication, right? You've done the blood and the ESR is raised. But you ask, do you have any problems with your vision? She says no. You go straight ahead, oral steroids, and then you go for temporal artery biopsy. But if someone comes, headache, I'm not feeling well, jaw claudication, some PMR symptoms, pain in the shoulders and things like that, and then they have eye symptoms. So it's like, oh, doctor, a week ago, they said this patient maybe had some visual loss, which was sort of just temporary for like 1 hour, so amaurosis for that, and then vision was restored. You should be worried about that and immediately start high dose steroids. So that's intravenous steroids, which we normally give for 3 days, and then get an urgent ophthalmology appointment. So I want to make that distinction, which I've highlighted in the slides, just so in case you are going through the slides later, you can remember it for revision. Okay. And then you remember we said these patients will be on the medications for like almost a year or two, isn't it? So that's a long time to be on steroids, and you know risk associated with long-term steroid use. So you need to be checking, doing a DEXA scan for this patient. Obviously, remember, they are females, they are elderly 80s, so they are even already at risk of their postmenopausal, obviously. So they are already at risk of osteoporosis. So you need to be doing your DEXA scans and then start them on some bisphosphonates, some vitamin D, calcium supplements, and then obviously some PPI if somebody will be on long-term steroids. And then if you've let's say, started somebody on steroids, the person has responded well, you are reducing or tapering the steroids gradually over a year. And then maybe when the person gets to, let's say, 20 milligram, for example, patient starts experiencing the headache again. Obviously, you need to reevaluate and see whether it's the GCA which is recurring again. If you see whether it's the GCA which is recurring again, you increase the steroids back to the previous dose, which was optimum for them, right? When you do that and you've done several episodes of, let's say, increasing their steroids, and they are still not responding to the steroids, then you can try other disease-modifying anti-rheumatic drugs. So things like methotrexate and leflunomide, okay? And then now, especially in patients who have very bad systemic symptoms, so very high fevers, very high CRP, you've started steroids, they have headache, jaw claudication, you've started steroids, but when you try to wean down, they sort of start having symptoms again. You can try what we call IL-6 receptor antagonist, so things like tocilizumab is just for you to be aware of, basically. As you can remember, during the pathophysiology, there was IL-6 involved, and IL-17, IL-12, and IL-18 as well. So this is used if, let's say, methotrexate is not working, steroid is not working, you can go to biologics like tocilizumab, right? And IL-17 inhibitors, for example, are no need to know, but just for you to be aware, there are new ongoing research into this, and IL-17 inhibitors like secukinumab have been sort of approved for use in the USA, not yet in the UK. So just one slide about PMR and then one slide about Takayasu arteritis, just so you don't have to go and read them separately on its own. I want you to remember them as part of this GCA sort of triad. As I said, PMR is female older than 50, presents with, let's say, subacute cause of pain and stiffness in the neck, and then in the proximal shoulder girdles, proximal upper and lower limb girdles. So shoulders, upper arms, hips, and then thighs, such that they can sort of raise their arms to pick things from shelf. That will be a common complaint, or they can stand up from sitting positions, okay? Their symptoms, the stiffness in the morning, it gets better as the day goes on, all right? And then obviously the obligatory constitutional symptoms with any rheumatic disease, fever, night sweats, anorexia, and then your raised CRP and ESR. And you have a good response to steroids with it. So if you give somebody steroids in like a week or two, they are not responding, it's probably not polymyalgia rheumatica, okay? And remember the association is associated with GCA. So anybody with GCA, about half of them will have PMR symptoms. Anybody who diagnosed with PMR, it's very important to ask about symptoms of GCA because the patients may not volunteer that, all right? And see what I've highlighted here, low dose prednisolone. So this will be like half of what you give in GCA is what you give in PMR. So you remember why I wanted you to sort of have it as a scheme. So in terms of treatment, if you have somebody with PMR, you give them low dose oral steroids. If you have somebody with GCA, you give them high dose oral steroids. If you have somebody with GCA with eye symptoms, you give them IV, intravenous steroids, okay? So I want you to look at it in that sort of, in that step ladder form of way. And obviously, if you've given them steroids, it's not working, you can try things like methotrexate. If it's not working, you can try biologic therapy. So just have sort of things like that in mind. And then Takayasu arteritis is the other large vessel vasculitis that you should know related to germ cell arthritis. It's normally called the pulseless disease. And it's like the twin brother of, or let's say the twin sister, since it's mostly in females, the twin sister of GCA, which who antagonizes GCA. So if you look at, for example, the demographics of it. So it's a young female, right? Compared to GCA, which is elderly 80-year-old female, this would be like adolescent or 20-year-old females. GCA is more in Caucasians. Takayasu arteritis is more in sort of Asians, so Japanese, Southeast Asia, India, and things like that. And then, what do you remember when we remember this diagram? This diagram at the beginning. Remember where Takayasu mostly affects? So it affects the subclavian and the carotid arteries, especially the internal carotid arteries, okay? So the symptoms will be, claudication. You have some bruits, which will show narrowing of the vessels in the neck or in the subclavian arteries, and then you have asymmetric pulses, okay? You can have some pain in the joints, pain in the muscles as well. And then in a young female who has occlusion of the renal arteries, you can have renal artery stenosis, which can sort of be a cause of secondary hypertension. So if you're evaluating a young person with hypertension, it's something to have in mind, especially a female. And then complications, as we said, aortic insufficiencies, dissections, aneurysms, congestive heart failure, and things like that. And then it's diagnosed with angiography, where you can see sort of narrowing of the vessels. So basically, angiogram to look at the vessels where they are narrowed. And then you start with steroids, and you can go on to methotrexate if it's not responding. And obviously, if these are not responding and there's very severe stenosis of an artery, which is causing, for example, limb ischemia anywhere, you may need to do an angioplasty or a bypass, isn't it? But the highlighted bits are what I want you to remember in case you see it in any exam at all. Young female, Asian, claudication, so radioradial delay, absent pulse on, let's say, one hand, or patient has renal artery stenosis, right? Diagnosis, angiography, steroids for treatment. You can use methotrexate if steroids don't work. So this is an angiogram of someone with Takayasu arteritis. You can see narrowing of the left subclavian artery here, and then narrowing of the left axillary arteries here. Okay. And this is a scheme, just what I've said basically in a diagram form. So when you have the slides, you can sort of go through for revision. Okay, so young lady compared to elderly ladies in GCA, Caucasian, Asian. The vessels are affected, mostly the outer, sometimes pulmonary arteries in Takayasu, but then the cranial and sort of external carotid arteries in GCA. And then the symptoms will be mainly claudicant symptoms in Takayasu arteritis. And then germ cell arthritis will be your headache and jaw claudication, things like that. And imaging, as we said, angiography, you can use MRI, PET in Takayasu, and biopsy and temporal artery ultrasound in germ cell arthritis. All right. So in summary, I want you to suspect GCA in any elderly female greater than 50-year-old who are coming with a new onset headache with scalp tenderness, jaw claudication, and any systemic symptoms. There'll be raised inflammatory markers, ESR especially, and then you start steroids promptly before even diagnosis, okay, to prevent the visual complications, all right? And then diagnosis is with temporal artery biopsy, which is 100% specific, but because of skip lesions, you may have some false negatives, all right? So ultrasound use is becoming common. You start with your steroids. So just going over again, low dose steroids for polymyalgia rheumatica, high dose steroids for GCA without eye symptoms, and then GCA with eye symptoms, IV methylprednisolone, okay, so IV steroids. If that's not, if you've tried steroids for a long time, patients are relapsing, you can try methotrexate and tocilizumab in refractory cases, all right? And then these are my references. So I want you guys to now have a look at the question, okay, the question at the beginning, and then after this lecture, let me know your answer. So you can just write by means of whether you think it's A, B, C, D, or F, and then after that we take questions and end today's session. I hope you guys all had I hope you guys all have the MCQ. I sent an MCQ at the beginning of the lecture so you guys can read because it was a long it was a long case. So it's here again for anyone who doesn't have, maybe you guys can send it to each other in the chat if maybe someone doesn't have it. And then you can let me know what you think the answer is. In case someone doesn't have, I'm sending the question again. You can, Anybody can either unmute and tell us what he or she thinks the answer is, or you can write in the chat, okay? And then we can just discuss, take questions, and then end the session today. Anyone has any thoughts on the answers? On the answer? Okay, so some people think B. Okay, so a number of you think B. Okay, B. I think B, most people say B. Any other different or different views? Okay, yes. Okay, so yeah, you guys are right. So the answer is B, obviously, because of the visual disturbances. So that's right. So I think it's a case that sort of encompasses or summarizes what I've basically talked about, right? So a 68-year-old woman, so woman more than 50, has some visual loss which came on, she's been having for some time ago, but then has had sudden onset vision loss, and then has had headaches with some, which has not responded to analgesia, and is having some systemic symptoms. So obviously this is GCA with involvement of the eye. So with visual symptoms, go for steroids straight. So you don't need to think about, so you don't need to think about imaging, because once it's GCA, the next step should be treatment before even imaging. So F and E are basically out. There are no other symptoms to suggest anything like, let's say, a stroke or any space occupying lesion. Is not vomiting, then she doesn't have any focal neurology. So you shouldn't even think about imaging. So E and F are out, right? Idosacetazolamide is for sort of glaucoma, right? There are no symptoms or data suggest glaucoma, or definitely glaucoma wouldn't come with these other systemic symptoms as well. So that is out. B is the correct answer because GCA visual symptoms, go high dose steroids. And then C, oral dose prednisolone, which would have been correct if she was not having oral symptoms. And then D, again, it's not used acutely, it's down the line when you've used steroids several times and they are not working or patients are relapsing, then you can go to methotrexate. So yeah, so that's good with regards to the question. Any clarification or any questions anyone wants to ask, you can write in the chats, and or maybe any area part of the slides that you want me to go over again. Otherwise, I'll send I think some of you have been asking about the slides. So I'll send the slides to you now so you can sort of revise with the highlighted portions, like the places I've put in before the exam. Any questions or anything? So you guys see, vasculitis is not that complicated, right? Or you disagree? Anyway, next week I'll try and we won't go into details, but again, when you see an exam, either for exam or in clinical practice, to sort of know how to deal with small and medium vessel vasculitis. So just sort of an overview, and then later we can do questions relating to all of them like we did last time with the inflammatory arthritis, okay? Any questions or comments? Okay, So it means you guys have understood everything and then answered the question correctly. So next week, and then let me know if you guys really want it on a Sunday or Saturday. Mostly I work or I have weekend shifts on Sunday. So, but if it's Sunday that you want, I can see if I can do some swaps and stuff. So let me know if that's more convenient for you. And kindly try and fill the feedback forms for me so we improve it and I pitch it at your level and what you really want to know. Okay. All right. Have a nice weekend in the absence of any questions or any further comments, and then see you next week. Okay. Okay. Thank you guys too.